pattern that we may see in PSC, which is central regeneration of the liver. Now, up until recently, we thought this pattern was unique to PSC, but we've now more recently, reviewing our experience with sarcoidosis, have found that sarcoidosis may also show this appearance. And this is a fairly nice example of that. So let's now look at the images. These are our coronal T2-weighted single-shot images. Again, remember to take a survey of everything in the abdomen. And what you notice is that there is enlargement of the entire liver, but I think it will become more clear on the transverse images that centrally the liver is more enlarged than it is peripherally. And that's why you'll see with time, with this pattern of PSC, that you get peripheral atrophy of the liver, and you can get a very bizarre appearance of heterogeneous T1 and T2 signal and the heterogeneous enhancement. Now here's our images now with fat suppression on T2. And you're starting to get the sense that there's peripherally the liver is brighter, reflecting edema from the related to the vascular compromise. And you get the sense that there are ducts that seem to be stopping where this, the more central liver has much more diminished appearance of vessels. And this is the appearance of central regeneration. And we are beginning to see the obstruction of the ducts by the centrally regenerative liver. Now, quite often what happens with time is that the central liver will be relatively normal in appearance, which will be normal signal on T1 and normal darkish signal on T2, whereas the peripheral liver on T2 will start assuming a brighter signal reflecting compression, reflecting that there's decreased venous withdrawal by the hepatic veins, so edema, changes of hepatitis, and on T1 that'll tend to be a little bit darker. But we will also see in non-contrast T1 weighted images in PSC segmental demonstration of high signal intensity on T1, which we think reflects inspissated bile in the biliary system. Now, this is a fat-only image as part of a modified Dixon sequence. Just going to go through our sequences. This is now sort of interesting sequences that we're working on. This is single-shot images, which with Siemens we call turbo flash. We actually think that this might result in some of the best non-contrast, non-fat suppressed image quality on for T1 weighted imaging in 3 Tesla, and this is for us a work in progress. This is the out of phase. We recognize that due to the black ring around the kidneys. So out of phase, we see these wedge-shaped areas in the periphery, and some of that may reflect the compromise from the central regeneration, the vascular compromise that we're seeing now peripherally in the liver. This is now our conventional 3D fat-suppressed image. Again, we can use this sequence as a template for enhancement. Remember that we can't use it's actually a water-only image, although it looks the same as a fat-suppressed image. We can't use the water-only image of a Dixon to use as a mask for post-contrast or to use as a background to determine enhancement using region of interest measurements. We have to use the exact same sequence, the exact same parameters to be able to use that as a mask or to make single intensity measurements. So look now at the arterial phase images. We get the sense some of this is going to be near field high signal from the coils, but a lot of this is actually as well the peripheral changes in the liver of peripheral atrophy. And notice how these ducts seem to obstruct at the level of the large central regeneration of the liver. Again, when you see that, the first entity I think of is PSC. The second entity now I think of is sarcoidosis. Distinct from chronic Budd-Chiari syndrome, the IVC should not be compressed. You should see the hepatic veins, and you will not see intrahepatic collaterals, as you tend to see in chronic Budd-Chiari syndrome. So just going through our images, again, most of our time we want to spend on the arterial phase images, looking for masses, recognizing that in PSC, hepatocellular carcinoma is uncommon, although it does occur. I would say at the same time, cholangiocarcinoma is relatively uncommon in this entity, and it can be tricky when you're dealing with PSC with dilated ducts to know when you're developing cholangiocarcinoma. For me, the important thing is to observe a sudden development of high-grade biliary dilatation where the thickness of the bile ducts really haven't changed much. That, to me, is a very good indicator that the patient has developed, in the meantime, cholangiocarcinoma. So, this case was an example, then, of liver disease, inflammatory disease, with a specific diagnosis of primary sclerosing cholangitis, showing you the distinctive pattern of central regeneration of the liver. Thank you. Now,